Friday. Okay, I was going to spend today just kind of reviewing. I have to go through the homework and enter the points, so I was hoping to do that while you guys are taking the test. The test will go live. It's actually at 3:30 because I have to edit a few more questions. So if I open it up as soon as we are done, I can't do that once people start taking it. So it'll actually go live at 3:30 instead of 3:15, which is only 15 minutes. But you have until tomorrow at, I think I ended it at 2:15 instead of 2:30 so that there's a buffer from the end of the test to class. So we're not running into being late for class. So as long as you start it, if it ends at 2:15, I think by 1 o'clock, you should have tomorrow, you should have plenty of time. So hopefully that doesn't conflict. Nobody seemed to have an issue with that for the last test. So if anybody has an issue, let me know. And yes, so are there any concerns? I mean, unmute yourself if you have a concern with anything. Again, the Monday and Friday groups, you're just going to have to find a way to get to class and be present. Okay, so the big things with chapter 8. Now, chapter 7, which we talked about the study guide on Friday about the locals, which is analgesia, but chapter 8 focuses on true analgesic agents. And the big thing that I also wanted to say, there was a question on what's physiologic and pathologic pain. Caitlin, I'll check here in just a bit if I got your homework. But physiologic pain doesn't necessarily mean there is actual pain. It can be the anticipation of pain. Like sometimes when you think a stove is hot, you don't actually burn your hand, but you're kind of like the body is anticipating that something could be painful. Pathologic pain actually is the pain itself. So the surgery, smashing a hand, cutting, the actual pain. And then we talk about pathologic pain, is we can get into, like in the PowerPoint, it talks about how do we classify it. It can be inflammatory pain, cancer pain. It can be origin, visceral, which is organ, somatic, which is anywhere on the body, like muscle pain and bone pain would be somatic pain. Abdominal pain would be like a visceral pain. And then it can be mild, severe, and anything that's idiopathic pain is like we can't figure it out. Sometimes in people, they have a source of pain, but we cannot find a problem that would cause that pain. Phantom pain, if an animal has an amputation or people that have had an amputation feel like the limb is still there. So that's what I was looking for there. So pathologic pain, also remember it can be classified as acute and chronic. If we spay a dog, that is acute. The animal did not come in painful. Chronic would be like arthritis or cancer, and that's been a pain that's been going on for some time. It's in your PowerPoint, but the 4 steps to the pain process is transduction, and that's exactly when they feel the pain, and then it is transmission. So then an impulse is created to transmit it. So transduction, transmission. Once the spinal cord receives the impulse, it's going to modulate it, which just means it can amplify it or it can somewhat suppress it. The best way I can describe it is in us is if I touch a hot stove, I am recording. If I touch a hot stove and I yank my hand back, that signal was amplified. If I think it's hot and I don't do this, I kind of just go, then that's been suppressed. So modulation is just the spinal cord deciding, do I need to speed this up? Is the response not needed? And then once it reaches the brain, that is perception. So once the brain can sense that something happened. So it's transduction, transmission, modulation, and perception. All right. AJ, stop. Oh my God. He just found a roll of paper towels like 10 minutes before this. So I've ripped up paper towels all over my house. Now, nociception is the actual sensing of the pain. And so when we talk about nociception, you know, a painful stimulus has been sensed. One of the things going back to chapter 7 is when we do a local analgesia or local anesthesia, the signal is not sent because remember it blocks the sodium channels. So what happens is the brain can never perceive pain. Nociception is never achieved. So nociception is once there's been a sensing of the pain, so to speak. And one of the key things is, I said, what is the goal of multimodal therapy? Multi-modes is when we have a pain protocol. Now, I'm not just talking, in this lecture, I'm not just talking about pre-meds. I'm talking about from pre-meds to home therapy. We can use different agents to treat different receptors. So it's using multiple agents to treat pain via different pathways. So the goal of multimodal therapy is to treat using multiple agents, which is safer, but it also achieves better analgesia. Consequences of untreated pain. Obviously, wasting away, avoidance behaviors. If a dog had an awful painful experience at your clinic, do you think they're going to want to come back to your clinic? And the next time you treat that dog, they start to feel painful again. Delayed wound healing. And obviously, one big thing is increased anesthetic doses. If I take an animal to surgery without a pre-med, I can tell you, you're going to have to use a lot more propofol. You're going to have to use a lot more isoflurane than if you give pain meds before surgery. So it's anesthetic sparing is a key thing. Two things also, primary versus secondary hyperalgesia. So primary is when, if we like say there's a laceration, the nerves here are going to fire. The dog might be sensitive anywhere near the limb because the neurons are in a hyperexcitable state. If you don't treat that pain, eventually what happens is it keeps firing to the spinal cord, and then the central nervous system gets overstimulated. And then you have this thing called wind-up, which is also secondary hyperalgesia. What happens there is you might touch the dog on their head. It's nowhere near the wound, but that dog is in a very hyperalgesic state. So our goal with preemptive analgesia is to keep us out of secondary hyperalgesia, which is wind-up. And you get to use lower doses. If you can achieve analgesia, you're not going to have higher doses. But I promise, if the animal, once they feel pain and they're in wind-up, you're going to have to use much higher dosing to achieve the same level of analgesia. Now, one thing that I know sometimes students get a little bit confused is a physiologic effect. I can't see a physiologic effect in the body. Okay, I mean, so the problem is when blood pressure goes up, ACTH is released, which increases cortisol and norepinephrine. All of those things are happening inside the body. Now, do I listen to an increased heart rate? Sure, and that can be an effect of physiologic changes. So physiology is things that happen if we don't treat the pain. ACTH, cortisol, sympathetic stimulation, increased heart rate, increased blood pressure. What does that do to my patient? Predisposes them to arrhythmias or abnormal heartbeats, because what it does, it makes the heart muscle excitable, increases blood pressure. So therefore, these are side effects that can affect my patient. So I have to be cautious. I also talked about preemptive analgesia, treat the pain before it starts. I also said, what are the differences in how animals respond to pain? And this is key. A young patient, I said in my lecture, puppies and kittens, you can be doing something minimally painful. They act like you're killing them. I'm sorry, if you own a husky, they act like you're killing them 24/7 when you just do something simple. Maltese, like certain breeds are very sensitive and certain breeds are very stoic. Like Australian Shepherds are renowned. I mean, that dog has to be in extreme pain for it to act like it's painful. They're a very stoic breed. I've seen some Aussies with terrible cancer, and and they act like almost nothing's going on. And I'm like, oh my God, if that was a husky or a Maltese or a poodle, they'd probably be screaming bloody murder. But this is an Aussie that's like, whatever. Cattle are stoic. So cattle tend to hide their pain. And then let me talk about dogs versus cats, because dogs, now I'm not getting into breeds, I'm talking about species. Dogs tend to be clingy, whiny, in your face. They might not be eating, but a cat is going to kind of like pull away. So cats tend to hide. They tend to not groom. I mean, if an owner comes in and is like, my cat looks like crap, their coat is unkept, you know, there's something going on. Sometimes that means a sick cat or a painful cat. Hiding, avoiding, also not eating. So those are things an owner is also going to notice. Physical evidence of pain. Now, when you take a history, you have to pull out of people what's going on. And so I'm like, well, what are they doing at home? They don't want to go upstairs, don't want to go on a long walk. They don't want to lay down. Like I've said this in lecture, my dog lays a certain way the majority of the time. I'm going to probably tell if he's, like abdominal and chest pain, you can't usually see something on the outside. But you have a dog that's like, we had a dog that just, the owner says he just won't lay the right way. Big abdominal tumor we found. Well, he's probably laying down and the tumor's pushing on things. So you see what I'm saying? It can be like change in activity, vocalization, things of that nature. And then one key thing that I mentioned in the notes is, and I've neglected to mention this in recovery lecture, when you wake an animal up from anesthesia, remember they go from awake, excitement phase, stage 3, plane 1, they're anesthetized. When you wake them up, they go the opposite direction. So there's the stage 3, plane 1, stage 2, stage 1. Some dogs hang out in the reverse in stage 2, and it's called emergence delirium. They're screaming, they're paddling, they're vocalizing. If you literally look at these dogs, they're not looking at you. They might be like flailing their head. They're not here. If it is truly that stage 2 coming out of anesthesia, emergence delirium, you can usually hold them and be careful because, again, they don't know what they're doing in that stage. If they bite you, if they flail their head, you have to be really careful. But generally in about 5 minutes, maybe 10 minutes, they usually come out of that delirium. And you can usually, some gentle assuring the patient, calming them down, will usually take care of that. If you have an animal that, 10, 15, 20 minutes, they're still screaming out and paddling and vocalize, trying to throw themselves around, there's a good chance that it's pain. But when it happens in the first 5 minutes, I generally try to see, can I calm them down? Do they come out of it? So that's the difference between true post-op pain and emergence delirium. And you need to know the difference between the two. It said be familiar with assessment tools, which is just like a picture scale, a pain scale. The only difference is an animal can't say, I'm a 7 out of 10, I'm a grimace face. So we have to look at their behavior, their vitals, owner history to try and figure out what level of pain. Because again, you're either going to have an animal coming in for surgery and they're 100% normal, or you may have a trauma that comes in and is, you know, not quite. You did not. Okay, I'm going to get to 15 here. I'm almost there. On 14, it says, how do we know we've achieved analgesia with our patients? Heart rate comes down, respiration comes down. Maybe they start eating. Maybe they lay down. Maybe they're more interactive. They just look comfortable. Maybe they start walking normally. So think about what a patient would do if they hurt. And then obviously once we see these behaviors go away, then we probably can be pretty confident that we've achieved analgesia. What are the stage 15? What are the stages we need to provide pain management? Now, what I was looking for with this question, I know is kind of vague and I apologize. Preoperatively, intraoperatively, postoperatively, and home care. Yes, some people put transduction, transmission, modulation. No, what I was looking for, what are the stages that an animal, that we're going to have them at our hospital? But pain management doesn't stop when they leave the clinic. Most animals go home with some type of pain medication, and that depends on the surgery, the patient, the owner's comfort level medicating their animal. So what level, but like I'm saying, it starts even before the surgery. So again, the pre-med, preemptive analgesia, but I will tell you guys, sometimes we do a surgery and I have a hard time keeping them asleep. Their heart rate keeps going up, they might try to move, and I've had doctors say, you know what, give them another shot of morphine. So during the surgery, I'll give them a shot of morphine. Heart rate comes down, turn my ISO down. When they wake up, they're painful. But then also, for the next 3 days, that dog is healing and, or for 2 weeks, they're probably going to be on something to make sure that they're not painful while they're healing. So hopefully, Caitlin, that answered your question. How do we choose an agent for pain? So a lot of this is going to determine what is the surgery. Is it a broken toenail? Is it a femur fracture? Is it a dog? Is it a cat? Is it a pediatric? Is it a geriatric? Is it healthy? Is it sick? So there's different levels of drugs. Some are very potent. Some are very light. Some of it's doctor preference. You'll get to know your doctor and you'll get to know, I worked for a criticalist. He was a big hydromorphone guy, worked for doctors that love fentanyl, worked for doctors that only use butorphanol. So some of it is doctor preference. Some of it's what do you have at your practice. But if I'm looking at my patient, a neuter versus a femur fracture are different levels of pain. Both need pain medication. That's kind of going to determine it. So, in clinical signs, how painful are they? But again, I can't impress upon you enough. If I have an Australian Shepherd, so this dog, and I still remember to this day, half of his mouth was a tumor and his teeth would hit the tumor. So I can't only imagine how bad that would hurt. And this dog ate dry food on that side, played, interactive. Now, if I look at this dog on the outside, it does not act painful. Do I know that that tumor hurts? Yes. So, should I give it something for pain? Absolutely. It doesn't have to be screaming and flailing and super high blood pressure. I mean, we got to do something for that dog. So, The stoic dog and the crying out dog both need pain management. Okay, so let's get into the agents. And I've already talked to you. You've got what you have to understand about opioids is their families. Pure agonists, agonist antagonist. Okay, pure agonists are morphine, fentanyl, hydromorphone. Agonist antagonist is butorphanol. Partial agonist is buprenorphine. Those are our agents. And the pros and cons is obviously, now I'm not going to go through each one because we're going to be short on time. But like morphine is dirt cheap. Hydromorphone's more expensive. They're more sound sensitive with hydromorphone. Fentanyl is the most potent agent we can use, but you have to give it IV unless you're giving it in a patch. But it's a very short acting drug. So if you give it in the muscle, you would be giving that dog a shot in the muscle every half hour. And I don't know about you, but I don't want to do that. I wouldn't want a shot every half hour in the muscle. So if I have the ability to go IV, I might use fentanyl. If I want, hydromorphone is a little more potent than morphine, except it's more expensive. So some people carry morphine because it's cheaper. So you see, there's all these pros and cons, and I hit some of that in the lecture. Butorphanol is a Schedule 4, and it's an agonist. It's the only agonist antagonist. So it's not as potent. If you really want to treat pain, you use a pure agonist. Morphine, hydro, fentanyl. Those are going to be, that's what I want if I hurt. Butorphanol is not, spay, neuter, minor laceration, broken toenail. Butorphanol will probably be fine. The nice thing about butorphanol, it's expensive, but it's not a high schedule. And it does have a tablet form, but it does have pretty decent sedative properties, which makes it sometimes a good choice. If I want to, again, opioids are never primary sedatives, but if I had to pick one that had good sedative properties, it'd be butorphanol. Buprenorphine, our advantage there, it's a pure agonist, it's a Schedule 3, so decent for pain. It's our only partial agonist. But it is great for cats because it has the long duration. It lasts like 6 to 8 hours. Sometimes by mouth you can, or sublingual, you can get up to 12 hours. So the nice thing is, it's not like I have to have an owner give this every 4 hours. I can send it home and say, give it every 12 hours. So it has that longer duration. Now, the one thing that you heard me mention was about fentanyl. Does come as a patch, but remember the things I told you about fentanyl. Wear gloves. It gives you 72 hours, but it takes 12 to 24 hours to kick in. So normally, like if a dog comes in hit by car, I'm not putting a fentanyl patch on them because I need something now. But if it's going to be post-op or send them home, you would put a patch on, but for that first 12 to 24 hours, while it's kicking in, you need to give something like hydro or morphine. And then after 12 to 24 hours, the patch kicks in, 3 days. But remember, at home, no heat increases absorption. Owners need to flush down the toilet, watch around kids and other pets, because if it's ingested, and then I watch the dogs for sedation and not eating, constipation, all the opioids too can cause constipation. So make sure that they're defecating. But fentanyl, the big thing I worry about is respiratory depression. It's pretty potent. So maybe teach the owner how to watch your respiratory rate. Have them watch their dog breathe in the room. Say, this is what you should see. And then I said, what other ways can you give opioids besides IM, IV, sub-Q? Sublingual. I don't typically give them rectally. We do some drugs rectally. That's not common, but you can give it sublingual. You can give an oral tablet. You can give it epidurally. Okay. And then obviously topically with a patch. So you do have some flexibility. And then, and remember, when we use it in cats, you're giving it sublingual or buccally. In the cheek pouch is buccal. Sublingual is under the tongue. You don't want to put it on food. You don't want to put it in water. It's supposed to touch the mucosa. So if they eat it, I mean, obviously they're going to swallow a little bit, but if the owner's pretty good, it's a very small amount. If they stick it under the tongue, it should just coat in their mouth and they absorb the drug. So not every time an owner sees oral, they're like, oh, good, I can put it in its snack, its meal. It's not how it works. It's going to be ineffective. Now, NSAIDs, non-steroidal anti-inflammatories, basically are inhibiting tissue hormones called prostaglandins. Prostaglandins cause inflammation. NSAIDs want to counteract inflammation. That's how they work. So there was a list in your PowerPoint. I want you to be familiar with the trade names. I went over those in lecture because, carprofen is Rimadyl. So be familiar with those. But basically, this is key client information. They cause GI upset in some animals. So if there's vomiting and diarrhea, not eating, drooling, melena, I didn't mention that, but if a dog has a stomach ulcer and the stool comes out black, that means there's probably some GI bleeding and the stool will appear darker. They need to call us and discontinue. Also monitoring liver and kidney because of metabolism. These drugs can affect the liver and kidney. So if we're going to use NSAIDs, we have to make sure our animal ideally has normal liver, normal kidney. And usually we recheck that after they take those drugs because we want to make sure we're not causing a problem. Now, let me give you an example though. I didn't mention this in lecture. If a dog is sent home on Rimadyl after a spay, usually they do 3-5 days worth. We're not checking blood work. I mean, we probably already did pre-op blood work, but we're not going to check blood work again because they only got 3 or 5 days. I'm talking about checking blood work if this is a dog with chronic pain and we want to keep giving that drug for an extended period of time. Okay, so if it's just 2 days, 3 days, 4 days, we're probably not going to recheck lab work. It's only for our chronic guys. So tell the owner those are key things to look for. Remember, ketamine and alpha-2 agonists like xylazine are sometimes added to protocols. Now, one thing people put on the test, I think it was the test, I said, in Kitty Magic, what is the analgesic? What is the sedative? What is the anesthetic? The analgesic was butorphanol. Okay. The sedative is dexdomitor, and the anesthetic is ketamine. I gave partial credit if you put ketamine as the sedative, and I gave partial credit if you put dexmedetomidine as an analgesic. But in that protocol, each has a main job. So in Kitty Magic, the main job of butorphanol is analgesia, the main job of ketamine is an anesthetic, and the main job of dexdomitor is a sedative. Always know the drug's primary job. When I give ketamine to a patient, I'm inducing them. If I do an MLK drip, which is morphine, lidocaine, ketamine, ketamine in there is used as an analgesic, but it's in sub-anesthetic doses. So the dose that they're going to get in a drip is much, much lower than if they were going to get it as an anesthetic. So ketamine does have analgesic properties. It is not a primary analgesic. It's kind of like an adjunct. It's like a nice little side effect. Hey, I'm using ketamine. Oh, great. It's going to help them feel better. Same thing with alpha-2 agents. Dexmedetomidine and xylazine are sedatives. That is why they sedatives. Now, why do people have kennel before class is done? Kennel should be starting after my class. You guys got to do what you got to do, but kennel is not supposed to start till my class is over. This is starting to make me a little upset. Okay. Okay, so Mackenzie, I'm not sure why you have to leave for kennel early. Are you talking about leaving your house? Oh, I thought you meant you had to leave the talk to start kennel. I'm sorry. I'm getting protective of my class. I'm understanding what you're meaning now. I mean, if you have to leave, you have to leave. This is going to be recorded and I will post it as soon as we're done. So Mackenzie, you can. Okay. Well, I'm understanding that now. I didn't understand. Nothing I can do. Okay. So just remember, if I mention something about xylazine, dexmedetomidine, or ketamine, what they have in common is they have analgesic properties, but that's not the main reason we use them. If they are part of a protocol, it's going to enhance analgesia. Let me talk about gabapentin and tramadol. Gabapentin and tramadol is part of the multimodal and analgesia protocol. So tramadol is an opioid derivative. It is a schedule, I think it's a schedule 5 right now. And schedule 5, oh, yes, please check NPOs. Please, please, please check NPOs because it's very frustrating to come in to try and state a patient and they've eaten. It really throws off the schedule. So please double check those. Oh, Michaela, let me repeat really quick. In Kitty Magic, what I was saying on the test, I asked, what is the analgesic and what is the sedative? The analgesic was butorphanol. The sedative was dexmedetomidine. Ketamine is the anesthetic. But people got partial credit because ketamine does have sedative. I mean, it's an anesthetic. And dexmedetomidine does have analgesic properties, but each one has a primary job. Anytime you have a protocol, each drug has a main job and a neat little side job. Think of it that way. Butorphanol's main job is analgesia. That's its job. Does it give me some sedation? Sure. Not the main reason I'm giving it. But it's a nice little, hey, there you go. So if you think of it that way, everybody has a main job and a side job. Gabapentin and tramadol enhance other analgesics. So gabapentin treats neuropathic pain. Tramadol does work on opioid receptors. It's an opioid derivative. And I said, why do we use caution with filling tramadol? People abuse it. So we normally, because it's controlled, we send home a small amount. Owners can get refills, but it's not like, okay, 6 months of tramadol and, oh, we haven't seen your dog for 6 months, so let's refill this. It's not going to work. So ideally, when we give tramadol, it does enhance the pain, it treats pain in a different pathway than Rimadyl, and GABA treats pain in a neuropathic, kind of like calms firing nerves. So we use them. And another thing, let me mention, when I add GABA, if GABA and tramadol are added to a protocol, it can be a dog's not responding to Rimadyl. So we're going to add some other drugs. So it can be that tramadol is not working, let's add GABA. Rimadyl is not working, let's use tramadol. But I will tell you, at VCA, most big surgeries go home with a NSAID, gabapentin, and tramadol. They can all be given together. They enhance each other. So owners sometimes don't want to put their dog on a bunch of drugs, but if you explain to them the reason we're using 3 drugs, we're not trying to drug your dog. Okay? We're trying to make them feel better. And while I'm on that subject, non-steroidals do not cause sedation. Okay? I get that all the time as an answer. They do not cause drowsiness. The only drugs we send home that will make them drowsy are fentanyl patches, potentially butorphanol tablets, but we don't usually use those because they're so expensive. Fentanyl patches, tramadol, and gabapentin. Yes, so Kirsten, it's a very similar thing to a balanced protocol like a pre-med. Multimodal analgesia is a balance of using multiple agents to treat different pathways. See, gabapentin, if you have a dog with arthritis is inflammation. That dog needs a non-steroidal anti-inflammatory. But there might be some nerve pain associated with the arthritis. I can give gabapentin, which will calm the nerves, and I give Rimadyl, which decreases the inflammation. So you see, instead of just treating inflammation by itself, I can add another drug to the protocol, and I'm treating via multiple pathways of pain. That's the idea of this balanced protocol. Yes, well, you're right on the money. We're balancing different agents. I'm just amazed at how many owners think we're trying to drug their dog. Like, oh my God, why are you sending home so many drugs? It's a good thing. We're trying to help your dog. We're not trying to drug them. But I will say, I have a question. What are 2 home instructions for tramadol and gabapentin to tell the owner? The number 1 is sedation and not eating with gabapentin and tramadol. And tramadol can cause some constipation. So if a dog is having difficulty defecating, they need to let us know. Right, and so there is a question on here, 28. What is an example of a corticosteroid, which is prednisone? Corticosteroid is just a steroid. Some people say corticosteroid. The common term is steroid. You can never, never, ever, 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 never, ever, ever use prednisone and Rimadyl. You never use a steroid and a non-steroidal. You pick one. The reason we use NSAIDs so much is they are safer for the animal. Long-term steroid use causes problems. Okay, it's harder on, in the notes, it talked about stimulating the adrenal cortex, and then we can get into liver kidney metabolism. But in some cases, we dealt with it with cancer patients. Sometimes the dogs were in such a bad inflammatory state because of the cancer, we had to put them on prednisone. But they could not be on Rimadyl. So they cannot be given together ever. But you can use prednisone, GABA, tramadol, or Rimadyl, GABA, tramadol. Okay? But steroids and non-steroidals, no, no, no. If you're watching me, I'm doing weird hand movements. No, no, no. And then nursing care, don't neglect the nursing care. But that's really the main thing. I kind of just went through that really fast. Does anybody have any questions about locals, which was chapter 7, or chapter 8, which is analgesia? Okay, if there's no other questions, I'm going to stop this video. It usually takes about 5-10 minutes for it to compress, let me to get it to YouTube, and then to email you. When I first send the link, it may not be active right away. It depends on when YouTube gets it compressed. So usually what I do is when I make the video, I send you the link right away to get it sent out. But like I said, sometimes it's taken up to an hour for the link to go live. I don't think it should take that long. The test will be open just a little bit different. I have to edit a few questions, Caitlin. So it's going to open at 3:30 instead of 3:15. And it'll be open till 2:15 instead of 2:30. So I'm just changing the times by 15 minutes on either side. Questions. Let me see. I don't remember. I'll tell you 2 seconds. There are 39 questions at 70 points. And you have 75 minutes to take it. So the latest you can start tomorrow, so it's 24 hours again, the latest you can start it is 1:15 in order to finish, 1 o'clock. It ends at 2:15. Oh, I guess it is open at 3:15. I can't change that. All right, never mind. It's going to be open at 3:15, not 3:30. Oh, my question is fixed. Never mind. No, I fixed it. I forgot I did that right before I came onto class. Sorry, it's been a day. It's been a day. It's fine. I don't need to edit it. It's ready. It'll open here, but I'm going to end so I can record this video. And then I'm going to get, oh, yeah, let me tell you real quick, Caitlin. It came from I got your first one, Caitlin. I did get your second one. So, Caitlin, if you sent it, yeah, that's fine. Yes, I'm sure I got everybody else's. I had to get anatomy done in the new grading system, so I had to spend a lot of more time on anatomy this weekend, so I got to get caught up with you guys. I've been scanning through the homework throughout the weekend. I just have to get the grades entered. Michaela, I got both of yours, Michaela. Any other questions on here? Do you guys have any other questions for me? Miranda. Yeah, I got it, Miranda. I will read it here this afternoon. I did get the forwarded emails from you, Miranda. I just haven't had a chance to read it yet, but I will. And Caitlin, I haven't heard from anyone about what we talked about yesterday. Wait, I can pause this recording.